Hi, this is Brian Kim. I'm going to share with you case number 199 in the best way to do cataract surgery series. This is a 2+ dense lens, and this eye is filled with silicone oil. And so this patient was sent to me from their retinal specialist. You're going to see careful mechanical fracturing with double chop, cross chop. And you're going to see throughout this case, because of that oil, the posterior capsule is going to bulge towards me. But remember, because I'm doing mechanical fracturing techniques, which does not require ultrasonic energy or vacuum to fracture the lens, you're going to see a very easy and careful lens disassembly, even in the context of silicone oil pushing the posterior capsule towards me. So you can see the silicone oil bubbles. I'm using the corneal marker, which will help me to center and size the rhexis. I make my paracentesis incision first on the right side and then the left side, making sure I'm flat to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This patient has a little bit of a Bell's reflex. This is the right eye. This is intracameral lidocaine. You can see the swirling of the silicone oil. It's kind of a cool appearance. Pretty neat visual. And this is some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. Using the cannula to control the eye, this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready to enter, I turn the eye towards me with the cannula, and then I enter. Again, this patient has somewhat of a strong Bell's reflex. I'm using the cannula to hold the eye. The patient loosened up, so I go ahead and take the cannula out. Go ahead and puncture the center. Pull the tear towards me. And you can see I don't really trust the patient, so I go ahead with the cannula to help control the eye. And then I'm going around circumferentially with these rhexis microforceps from Moria. Going around circumferentially, you just have really exquisite control and chamber control with these forceps. And the sharp tip allows you to puncture it as well. And that's the rhexis. Finish off the rhexis, burp the viscoelastic out. And this is the capsule fornix hydrodissection technique. I'll place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, lift the lens up, decompress the bag completely. Sweep under the left side and then the right side, and the lens begins to spin. Irrigate the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Sliding the chopper under the rhexis edge, contra-incisionally, point the tip down, turning the phaco tip vertically sub-incisionally, fracturing the lens completely in half. You can see there's no translational movement of the lens, fracturing it through and through, placing the chopper around the right heminucleus, hooking the peripheral lens, pulling centrally toward the phaco tip, fracturing the lens completely in half, and that is the cross-chop maneuver. Placing the chopper around that first quadrant, crushing the lens in half, again with another cross-chop maneuver, using some vacuum to lift that piece up, and then crushing it into smaller pieces, and then emulsifying the lens piece, using some vacuum to grab that other piece up, crushing it between the instruments, and then emulsifying the lens piece. Again, you can see there's no translational movement of the lens with the double chop maneuver. You get good control of oppositional forces to crush the lens completely in half. Placing the chopper around that second quadrant, crushing the lens in half with the cross chop maneuver, and then crushing that fragment with the instruments, and then emulsifying the lens piece. Hooking the peripheral lens again, hooking the lens with the chopper again, crushing it in half. Again, when you get facile and comfortable with placing the chopper around the lens, it really isn't scary. It's just kind of routine. You just do it all the time. It's like the person who doesn't know how to do stick shift on their car. They get really like, whoa, you can do that. It's so natural. But the person who does stick shift in a car, it's just routine. They don't even think about it. They shift and they know how to do the clutch and the pedals and all that stuff. It just becomes second nature. Same with this. When you become comfortable and confident in placing the chopper around the lens, it's just part of your surgery. And so you never really run into trouble. You never have a situation where you're trying to grab the lens and it slips off, or you're struggling to grab the lens. That can happen when you have high vacuum, and that's because the lens material all changes in consistency. Every case is different, and it again therefore reduces your reliability and consistency of surgery. You have to go with a plan B, try to do it different ways. But when you always hook the lens peripherally with the chopper, you never run into that trouble. And that's why I feel like this is the best way, most consistent way to disassemble the lens. So all the endonucleus is gone. I'm removing the epinucleus, and the cortex just kind of all comes out at once. So I take the chopper out, push BSS in, take the phaco tip out, and you can see the convexity of the capsule. Isn't it amazing? The glistening of the silicone oil, the capsule is pushing up towards me. And again, because of my lens disassembly, I'm never fearful that I'm going to rupture the posterior capsule. Again, that all comes down to confidence with mechanical fracturing, crushing the lens with the instruments, by not having to rely on high vacuum. Again, if you have sudden loss of vacuum, you can get post-occlusion surge. That posterior capsule can fly up towards you. I never worry about these things because, again, I'm not using vacuum when I'm crushing the lens and disassembling the lens. And when I am removing the lens pieces, I've crushed the lens into small enough pieces with mechanical fracturing forces that those pieces come out rather easily, even with just a little bit of vacuum and pulses of ultrasonic energy. So go ahead and pulse the subincisional area with BSS, which was cleaned, and then filling the capsular bag with cohesive viscoelastic, and then using the sweeper to polish under the rexus edge on the left side and then the right side. You can see that there is some lens epithelial cell material. The posterior capsule has been effectively pushed back with the viscoelastic, and as a result, I'm able to place a single piece acrylic lens into the capsular bag. Go in with irrigation off, activate irrigation, disengaging each haptic off the optic, getting underneath the lens, tilting it, rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag. Pushing the optic back down, polishing under the rexus edge, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who is status post retinal detachment, had silicone oil in the eye, sent to me from the retinal specialist, had a dense cataract, silicone oil bubbles even in the anterior chamber. Again, the case went rather routinely, and part of that is because I perform mechanical fracturing techniques. I don't use high vacuum or ultrasonic energy to disassemble the lens. I just use mechanical forces to crush the lens into smaller pieces, using the chopper and phaco tip as two crushing instruments to crush the lens with opposing forces. This gives me extreme and exquisite control of the situation. And because infusion is activated the entire time, it pushes the posterior capsule back. I don't have to worry about post-occlusion surge. I don't have to worry about accidentally buzzing the posterior capsule with any of those maneuvers. And because I crush the lens pieces into small pieces, I use sparing amounts of ultrasonic energy and vacuum. This is really a great case to perform this maneuver. You saw at the end of the case when I remove all the lens material that posterior capsule was bulging towards me, and you saw the glistening of the posterior capsule from the silicone oil. But this patient did rather well. And so this is why I feel this is the best way to do cataract surgery, in particular in the case with silicone oil causing the posterior capsule to bulge convexly. So I hope this was helpful to you, and I thank you for your attention.